everybody. I am Elisabeth Arrojo, a radiation oncology from Spain. I'm very happy to be here today. I would like to thank the organization, first of all, for inviting me to be here. I would love to be there personally, but unfortunately, it has to be online, but I hope we can meet together very soon. So I'm going to speak about something amazing from my point of view, that is hyperthermia and immune system, a new milestone in cancer treatment, which I think I am sure all of you are going to consider that this is our future, because we know immune system is the key for cancer treatment and for cancer prevention. We are working in Spain a lot in this because we have the first prevention cancer center of Europe here in Madrid. I am the medical director, and I am happy to say that we are working a lot in immune system for treatment and also for cancer prevention. So we know that tumor has narrow aberrant vessels, and systemic treatment cannot go inside the tumor because of this. And we also know that those narrow vessels also create a problem, which is hypoxia. We know that hypoxia in cancer treatment is a very important tumor because on the one hand, the radiotherapy needs that oxygen enhancing effect. You know that oxygen is the one which is going to fix the damage to the DNA when we treat a patient with radiotherapy. So it's very important to have oxygen to increase the radiosensitivity of the tumor. So we also know that hypoxia can stimulate neoangiogenesis, which is going to increase the risk of invasion and metastasis. And we also know that hypoxia is going to inhibit, as you can see here, the dendritic cell maturation. So hypoxia is going to suppress, to inhibit immune system. We also know that radiotherapy and hyperthermia, and this maybe is not so known, but it's also important to know this, that hyperthermia and radiotherapy can stimulate antigen cell presentation. So you can see it here, how it can stimulate immune system. When we treat with hyperthermia, we are also going to stimulate antigen cell presentation, because as I said before, we are going to unblock those dendritic cell maturation. We are going to hit the head shock proteins, and this is going to increase that antigen cell presentation. But also we are going to open the vessels, and we are going to facilitate immune cell infiltration inside the tumor. So we are going to help immune system to kill malignant cells. But with radiotherapy, we have to take something into account. We know that lymphocytes are very radiosensitive, and we have to be careful because we are destroying, you can see it here, how with radiotherapy we are daily destroying lymphocytes because they are very radiosensitive, and with doses from more than 0.5 grays daily, we are going to kill a lot of lymphocytes. That is one of the problems of very long radiotherapy treatments. When we have a lot of treatments, we are going to kill a lot of lymphocytes, we are going to suppress immune system. This is a very interesting publication from MD Anderson in the US. Sorry, because I'm seeing that some slides maybe are in Spanish, but they are analyzing the novel use of low-dose radiotherapy to modulate the tumor microenvironment of liver metastasis. Nowadays, we know that patients with liver metastasis had been historically identified to respond poorly to immunotherapy. The liver is a very different organ which has a worse response to immunotherapy compared with other organs. So we know this is because the liver had unfavorable conditions. You can see how it's going to difficult the T-cell infiltration because it has a very dense stroma, it has low rate of macrophages, it has an increase in TGF and VEGF and fibroblasts, and that is going to make it very hard for immunotherapy to work. But we know from this publication and other publications also that with low dose rate radiotherapy is going to repolarize those macrophages, is going to decrease these fibroblasts, the TGF, the VEGF, and is going to facilitate the infiltration of T cells, as you can see it here, natural killer and macrophages. So low dose radiotherapy can change that microenvironment and can make easy the T-cell infiltration and the efficacy of immunotherapy inside the liver. So we also know that when we treat with low-dose radiotherapy to large areas of tumor, we can do a safe treatment without side effects and with significant responses. And I'm going to show you a case published also from MD Anderson. It is a patient with melanoma metastasis in the liver, lung, bone, and brain who progressed for a lot of time with 2 different immunotherapies, and finally they didn't have any treatment to give to the patient because of that progression. You can see here how the patient had this big liver metastasis. This one was 9.5 centimeters, and also this lung metastasis. And what I'm going to show you here is that they treated the patient with high dose radiotherapy to this lesion in the lung, 50 grays in 4 fractions, and then they treated the whole liver with a very low dose radiotherapy. They gave the patient 5.6 grays in 4 fractions to nearly the entire liver. So you can see this is the response 4 months after the treatment, and you can see how it's amazing because the patient had a wonderful response in the liver. But what is more amazing is that 19 months after the treatment, the patient had a complete response in the liver. So you can see how radiotherapy can have an amazing response. I'm going to speak a little bit also about this trial. I am sure you all know this trial about the effect of neoadjuvant chemotherapy plus regional hyperthermia on patients with high risk soft tissue sarcoma. This is a randomized trial from the EORTC. So you know that there are several countries in the trial. It's a phase 3, as I said before, ages from 18 to 70 years with histologically proven soft tissue sarcoma with a very big tumor, more than 5 centimeters, grade 2 or 3, deep to the fascia, without distant metastasis. The primary objective of the treatment of the study was local progression-free survival, and the median follow-up duration was 11.3 years. So the randomized 341 patients, finally 329 eligible for intention to treat analysis. The randomized chemotherapy with doxorubicin, ifosfamide, and etoposide versus that chemotherapy plus hypothermia. Here you can see the amazing results, how patients with hyperthermia, this line here, this orange line, had a significantly better local progression-free survival and also a significantly better disease-free survival. It is also amazing that the overall survival in patients with hyperthermia was also, as you can see it here, at 5 years, significantly better, because the median survival, and these results are wonderful, was 15.4 years in the patients with chemotherapy plus hyperthermia compared with 6 years in the patients with only chemotherapy. Of course, they performed a multivariate analysis where they found that hyperthermia was significantly better whenever they added it to the neoadjuvant treatment, and this was very important, of course. But what I would like to show you is this study. They also perform a protocol for studying the immune status of the tumor, of the cells of the tumor tissue in this study. So what they did is they randomized 109 patients who had a biopsy, a diagnosis in neoadjuvant treatment, before neoadjuvant treatment, and they had a second analysis when they had surgery after neoadjuvant treatment. So they found 28 patients who had PET samples, 13 with chemotherapy plus hyperthermia, 15 only with chemotherapy. What they analyzed were the infiltrating tumor lymphocytes with TD8, PD1, PDL1, and FOXP3. And they consider if they had a high-grade infiltrate, as you can see it here, or low-grade infiltrate of lymphocytes. So they compare, as I said before, those baseline biopsies, biopsy 1, and the biopsy after neoadjuvant treatment at the moment of surgery as biopsy 2. So what they found is that 53% of the patients had an increase in the infiltrating lymphocytes inside the tumor after that neoadjuvant treatment. And they also found that those patients with high lymphocytes infiltrates were had significantly better local progression-free survival, as you can see it here, and also significantly better disease-free survival. And what is more interesting in this study is that in the patients who receive also hyperthermia, those patients with high TD8 in the tissue, in the biopsy, had significantly better local progression-free survival and disease-free survival. So the patients with high infiltrates of lymphocytes and hyperthermia had significantly better response. When the patient did not have a high infiltrate of lymphocytes, there were no significant differences between both groups. So as conclusion, the preoperative chemotherapy with or without concomitant hyperthermia turned the state of a cold, non-immunogenic sarcoma into a more immunogenic tumor. And in patients with high increase in CD8, the addition of hyperthermia significantly increased local progression-free survival and disease-free survival. So we can see again here the immune effect of hyperthermia. This study, I'm sure all of you know, this study also is a phase 3 trial from our friend Dr. Minar, who studied the effects of modulated electrohyperthermia on 2 and 3 year survival on locally advanced cervical cancer patients. As you can see here, she found that adding hyperthermia to the treatment had a significantly better survival compared with only a standard treatment with radiochemotherapy. So she also performed another study to analyze the abscopal effect of the modulated electrohyperthermia when she combined hyperthermia with standard radio and chemotherapy. So you know, in this trial where patients FIGO 2B and 3B treatment naive, and they were eligible for chemoradiotherapy with radical intent. So they choose a group of patients for analyzing the abscopal effect evaluation. They needed a minimum of 6 months follow-up after the treatment. Of course, they needed a PET-CT just before treatment showing nodal disease outside the pelvic treatment field. And of course, they needed a PET-CT after treatment to compare both PET-CTs. The treatment was a standard treatment with radiochemotherapy or a standard treatment with radiotherapy plus the hyperthermia treatment. They consider a complete response on PET-CT as the abscopal response, And an important thing is that they needed to have a complete response in the primary, in the nodes within the radiation field, but also in the nodes outside radiation field. That's the important thing. The abscopal response is that you treat the primary, but you also have a response in another area which you are not treating with radiotherapy. So you can see here the wonderful results that the patients with standard treatment plus modulated electrohyperthermia had significantly better results compared with patients who received only chemoradiotherapy. You can see how the abscopal response in the modulated electrohyperthermia group was 24.1% versus 5.6% in the patients without the hyperthermia. There were no significant differences between the groups, so this is again something showing that hyperthermia can stimulate immune system. This is a case from our experience. It's a breast cancer case. She had a recurrence at the thoracic wall, and we treated her with radiotherapy, 2 grays per fractions, 15 treatments, so the final dose was 30 grays. And what is interesting is this in the right is before treatment, and this in the left is after treatment. And you can see this is the isodose of 5 grays, is 5 grays in 15 treatments, so a very, very low dose per treatment. And you can see how this node here significantly respond to the treatment. And this is abscopal response because the patient did not receive chemotherapy, did receive only radiotherapy, but the treatment area was the thoracic wall, not this node in the lung. You can see how big the node was and how was after the treatment. So she had a very, very good response without treating directly that node. This is abscopal effect. This is another case with lung cancer. We treated her with radiotherapy for this vena cava syndrome with 20 grays in 5 treatments. What is interesting is that this lesion, which did not receive any radiotherapy, also decreased after treatment. She was without chemotherapy treatment, so this is again abscopal effect. So this is our present and also our future, because we are already working at our center with low dose radiotherapy and hyperthermia to analyze the effects, the amazing effects over immune system. This is another trial we are doing. I think it's very interesting because we are combining hyperthermia plus radiosurgery, but not only for radiosensitizing. We are doing also because as we are not treating with radiotherapy the whole brain, we are treating only the lesion with radiosurgery. What we are doing is combining the hyperthermia also to achieve an abscopal effect in your brain, to eliminate that microscopic disease without radiation the whole brain. We are doing a study analyzing what happens in peripheral blood lymphocytes with radiotherapy plus hyperthermia versus only hyperthermia. You can see, for example, one case which is a breast cancer case with multiple brain metastases. We treated her with 30 grays in 5 fractions of radiotherapy plus 3 treatments of hyperthermia concomitant. You can see how in red you can see the days she received radiotherapy, and in green the days she received also hyperthermia. And you can see how after she finished radiotherapy, we went on for 3 treatments more only with hyperthermia. This is what happens when we combine radiotherapy plus hyperthermia in peripheral blood in lymphocytes. You can see here CD8, and you can see how they decrease, because I have said before that radiotherapy can eliminate a high number of lymphocytes when we use high doses. This is interesting because This is what we found when we analyzed the patient with only hyperthermia immunotherapy. You can see how CD8s increase after hyperthermia treatment, so it stimulates immune system. And just for ending, we know that immune system is the key for cancer prevention and cure, so we have to do more research on this. We also know that hyperthermia can stimulate immune system because it will decrease hypostia, it will unblock dendritic cell maturation. When we hit the head shock proteins, we will increase the antigen cell presentation. And when we treat with hyperthermia, we will create a vasodilation, which will make easier activated lymphocytes to go inside the tumor. So we also know nowadays that hyperthermia combined with low-dose radiotherapy and or immunotherapy has a very promising future in cancer treatment. Of course, we need more research. Actually, we are working in different centers. I am the medical director of the Medical Institute of Advanced Oncology. We have 3 centers in Spain. And I also work at a public hospital, University Hospital Marqués of Valdecilla in Cantabria, and I am also professor at University of Murcia, where we are doing a lot of research in order to move forward with this treatment. So you are invited to visit us whenever you want, and we will be happy to share with you our experience. Thank you so much.